Good morning, everyone. Happy Sunday morning to you. We'll just wait a moment to let everyone into the waiting room. So we'll just get started in just a few moments as everyone is filtering through. Everyone comes in one by one. Hope you're having a lovely weekend. I've been enjoying it. It will be nice when we can be back in person and see everyone and meet in the corridors and things like that, because that's kind of better for what Friends for Life really is. But I hope everyone is enjoying at least doing these Zoom calls in the comfort of your own home at least. So I hope everyone's sat there with a coffee or a tea, ready to crack on. I think we've still got numbers going up. Just wait until they steady off. Okay, right. I think we'll get started. So very good, very warm welcome to everyone today on Sunday, the last day, very sad, last day of the conference. Hope everyone's been enjoying it so far. I've been enjoying it. My son Hugo, who's in the tween group, has definitely been enjoying it too. Lots of laughter coming from his room when he's on the sessions. Before we get started, a huge thank you to all the sponsors that have enabled the conference to go ahead. If you haven't yet, please do visit the sponsor booths on the website and have a look and see what they have to offer there. Now, the session this morning is Type 1 Care Now and in the Future, and we're very lucky to have Dr. Brian Kennon here, who is a huge expert in the subject, he has a number of titles, a consultant diabetologist, the National Lead for Diabetes in Scotland, and chair of the Scottish Diabetes Improvement Plan. So we're expecting big things, Brian, and he will no doubt deliver. So what I will say before we get started, we have a chat function at the bottom. Do click on the button if you want to introduce yourselves, have any comments. And there's also question and answers. So if you'd like to type in any questions you have for Brian, please do that during the session and I'll do my best to put them to Brian at the end. So let's sit back and enjoy Brian. Over to you.
Yeah, thanks very much, Emma. Cheers. That was a big billing actually, which I'm not sure I'm going to be able to live up to, but I was thinking more of a 45-minute general catch up and chat, and I might try and cover some prevention things, some technologies, and talk about some virtual care models. So hopefully there's something in there for everybody. And I suppose the first thing to say, and Ken McHardy's closing the meeting, I think quite rightly celebrating the 100-year anniversary of the discovery of insulin. So I'd encourage you all to tune into that talk later on today as well. So yeah, so this is going to be a sort of general overview of a few different aspects of type 1 diabetes care, and maybe a couple of things that you've potentially not considered to date. And I'll focus on prevention first of all. And I suppose the first thing to think about when we think about prevention of type 1, we really need to understand how type 1 diabetes evolves. So this graph here is showing that when you're born, you've got your genetic makeup, and that genetic makeup will undoubtedly put some individuals at increased risk of type 1 diabetes. But our current thought processes are that you need an additional environmental trigger before you would stimulate the immune process to damage the cells that make insulin. And I'm sure most of you are aware, these are beta cells that are in the pancreas. So if you're thinking of prevention, it's about this element that you might be considering that you would want to intervene. But we actually know that you have to lose about 70 to 80% of your beta cells before you would actually manifest the clinical condition of type 1 with increased thirst, increased urination, weight loss, and all the features of insulin deficiency. And it's worthwhile highlighting along the bottom that's the time frame, because for some people that's a very quick process, maybe a couple of months, if not less. Whereas for others, we're increasingly seeing very, very slow onset immune processes that may occur over decades. And despite the textbooks when I was training saying that type 1 diabetes was in children and young adults and type 2 diabetes were in 50-year-old obese people, I think increasingly we're seeing people in their 60s or 70s presenting with type 1 diabetes, and conversely, kids in their young teens presenting with type 2. So it can be a variable feast. And I suppose the key question is, what are you trying to prevent? And I think that's the key thing you're trying to prevent is destruction of your insulin-producing cells. And apologies, but I'm not going to lie and say immunology is my strong point. So this is my attempt at basic immunology. And I've taken inspiration from the good, the bad, and the ugly. And the good, i.e. Clint Eastwood, would be your sheriff, so your regulatory T cells. The bad would be Lee Van Cleef, and these would be your assassins. These would be your killer T cells. And the ugly, so I'm going to give you a bonus point. If anybody in the chat function can tell me the name of the actor who played the ugly, and we'll pick that up at the end. But the ugly are really your B cells that are actually antibody cells that can make a bad situation worse, as I'll go and explain. So if we think of the immune process, and again, for any immunologists out there, apologies if I've oversimplified this, but your sheriffs are sitting there trying to protect your beta cells in the pancreas. But quite often in type 1 diabetes, they get overwhelmed. You just end up with more and more killer T cells, and eventually they'll become toxic to your insulin-producing cells. That situation is made worse by your B cells producing these autoantibodies. And the ones here that I've listed are the common ones we see in type 1 diabetes. So GAD, IA2, and ZNTNA is the technical terms. And these antibodies effectively shine a light or put a target on the back of your beta cells. And lo and behold, your killer cells are even more effective at killing your beta cells and causing progressive insulin deficiency. And the reason it's important to understand that sort of immune process is because when you think about the potential role of prevention, you have to think about when you can target an intervention. So in the green shaded area on this slide is primary prevention. So this is you saying that I'm going to intervene before the immune processes even start. Secondary prevention would be after the immune process has started. So there might be some beta cell destruction, but it's not yet a clinical manifestation. So that would be secondary prevention. And tertiary prevention would be after you've developed type 1 diabetes, is there anything you can do to try and preserve the 20 to 30% of beta cells that are left? And one of the reasons why preventing type 1 diabetes is so challenging is because type 1 diabetes is a multifactorial disorder. There's lots of different reasons why an individual might develop type 1 diabetes, and I've listed a few of them here. We know that genetic factors might explain up to 50% of your risk. So from identical twin studies, we know that in identical twins, if you develop type 1 diabetes, about half of the twins would develop type 1, but not all, only half. There's also a lot of work around viral illnesses potentially being triggers and seeing spikes during viral illness season. And one of the ones that are implicated is Coxsackie. There is some evidence that diet might be a predictor. And the problem with all of these is it's quite conflicting. Some studies show very positively that cow's milk protein may be a predictor of type 1, but others don't support that. So that's why we can't be definitive. And there's also some evidence that vitamin D might be protective, but again, that's not universal. Probably the strongest predictor are these serological markers, so these autoantibodies. So we know that the more antibodies an individual has, the higher risk they've got of developing diabetes. And I've got a circle here with a question mark because there are other factors that we just don't know as yet. So when you look at some of the primary prevention stuff, so some of the work that's done before you even start the immune process, there's been some work around oral insulin, some work around vaccination. There's a lot of interest about looking at your gut and all the different bacteria within your gut and whether that can be a predictor of type 1. But none of these have shown conclusive evidence of benefit, which is why primary prevention works fairly limited. We have got better at trying to identify those individuals who are genetically at risk of developing type 1, but we still probably don't have a robust intervention to stop them progressing. And this next slide probably highlights why prevention of type 1 is so challenging. So if we take the far side, so the dark red, and take the whole population who are at genetic risk, the big difficulty here is there'll be lots and lots of people who are genetically at risk, but many won't ever go on to develop type 1 diabetes. So putting in an intervention here is really challenging because you're potentially intervening in lots of people who might never develop that disease anyway. If you wait till the far end, the grey area, when you've developed clinical disease, then yes, you've definitely identified people who've developed type 1 diabetes, but by that stage, they've lost an awful lot of their beta cell function. So you've almost left it a bit too late, or certainly it's not optimal. And clearly the sweet spot is when you've got a risk, a genetic risk, and an immunomarker such as an antibody, and you try and delay the progression. And that's where there's been a lot of work. I'm not going to go into the various different studies in detail, but maybe to just flag a couple of web resources that if you were interested, you could go and look up. So there's a website called Address2, which is really trying to set up, if you like, people with type 1 diabetes and their families with researchers, so that if new therapies come on the market, you can start trials very quickly and you can target people who are potentially at risk. One of the big breakthroughs that came through, and this is now moving on to secondary prevention. So this is once you've already identified people who are at risk, so have antibodies. So this was a headline from March of this year that showed new research can show that a drug can delay type 1 by 3 years. And this was a study using a drug called teblisumab, which is what's called a monoclonal antibody. So it really affects the killer T cell. So it's really knocking out the assassins, if you like. And what they showed in high-risk individuals, so these were relatives of people with type 1 who had 2 or more antibodies, that if they gave them a one-shot course or a week-long course of this teblisumab, you could delay the onset of type 1 diabetes for 3 years. And the reason why that's important is because obviously if you can shift the curve so that children get diagnosed at a later age, or indeed you can preserve beta function for longer, then theoretically you could delay the onset of potential complications for longer as well. So really groundbreaking, probably one of the first studies to show that you could intervene in the type 1 diabetes disease process. There are quite a lot of different trials going on just now. And again, I'm not going to go into these in detail, but just to highlight that there is a type 1 diabetes UK network of researchers and trialists. And if you're interested, then you can look on their website. It'll give you information of the different studies that are recruiting just now. Now, many of them have to be within the first 100 days of diagnosis. And clearly, that's not a great time because you've already got an awful lot to deal with without worrying about taking part in research studies. But I'm conscious that for Friends for Life, you've got people from families coming from 2 weeks of diagnosis to 32 years of diagnosis and beyond. So there's a potential window of opportunity there for people who've been diagnosed early if research is felt to be appropriate. So I'm not going to talk any more about immunotherapy and about prevention, but that was just to give you a bit flavour of some of the work that's going on in the prevention arena. The next section is probably more relevant to a lot of you, and this is around diabetes technology. So here's a picture of the vast variety of different insulin pumps that we can available just now, and also the increasing number of glucose sensors that are out there as well. I've got G5 there actually. We're obviously using G6 now, and G7's on its way, even if Dexcom can't speak about it. And when we think about the technologies and how far we've advanced in the last 10 years, then we are on the brink, I think, of a significant breakthrough in how well technology can help manage type 1 diabetes. Sensor augmented pump, many of you will be aware of, but for some of you who, again, might be relatively new in the journey and haven't really heard of them or aren't aware of them, this is when your insulin pump delivers insulin continuously, can speak to your sensor, and then they can actually influence how much insulin that you're getting administered at any one time. And one of the first breakthroughs was something called a low glucose suspend. So when your blood sugar went low, your pump switched itself off. And I'm sure many of you on the call probably tried this technology when it first came out. That's advanced since then. So now it's got predictive low glucose suspend. And indeed now some of the commonly used pumps that we use have got algorithms to deal with high blood sugars as well. And this is sort of how it's viewed as a technology cycle or the advancement of technology. So we've moved through from low glucose suspend to number 2, which is predictive low glucose suspend. And I think probably now we're in the age of the hybrid closed loop. So this is a sensor speaking to a pump, that's trying to control your blood sugars automatically. However, you still need quite a significant degree of user expertise because you have to announce your meal and you have to be able to carb count to be able to announce your meal. We're on the edge of fully automated closed loop systems. So this is when effectively the technology will look after your diabetes in its totality, but that's single hormone. So in that instance, insulin. And then number 5, which is really the technological holy grail, which is the fully automated multi-hormone closed loop. And for those of you who saw Ed Damiano's keynote talk on Thursday, then very much the islet is about developing that dual hormone, so insulin and glucagon, fully automated closed loop system, so effectively a bionic pancreas. So I said that step 4 is really here and now, and I know that Candice Ward did a talk on the Cambridge APS system that's been developed by Roman Havorka and his team. And for any of you who were at the initial session and for this conference, we talked about the Dana pump linked to the Dexcom G6 and how the additional app or the CAMS APS can help control your blood sugar readings. And this is something that's now commercially available within the UK. What's coming, and again, if you saw Ed's presentation, is the islet, so dual hormone. And I know that they're in the final phases of their insulin devices, and they're also looking at developing sort of stable, long-acting glucagon. And I suppose the glucagon's key here because that's the hormone that's going to protect you against hypoglycemia. And unlike a lot of technologies that we use just now, then the islet only needs one piece of information, and that's your body weight. And it will run its algorithms based on your body weight, and it will learn from your glucose devices. It's got machine learning algorithms, as of the other systems. But this could potentially change how we manage type 1 diabetes moving forward. It's funny, I was speaking to Ed recently, and he was highlighting that when they were starting to use the islet in their sort of landmark breakthrough trials, and he probably talked about this the other night, is the people who tend to adapt the best are actually relatively naive pump users. So they're people who might be fairly new on in their diagnosis, who are fairly new to technology, because they just let the technology go and do its own thing. We know that if you've been on technology or you've had diabetes for a long time, it can take quite a lot to trust the technology to look after your glucose. And I think intuitively you think, well, why can that be? As a diabetes community, we've been crying out for sort of fully automated pancreas systems for ages. And yet when we get them, we're a bit skeptical of them. And I think a good analogy that I heard, it's would you go in a self-driving car to get, to go out about your daily routines today? And I think most of us, despite being drivers, would probably be a bit wary of that. And that's true of diabetes as well. It's worth highlighting, and I mentioned this the other day when I was speaking, that we do know that with the newer technologies, the more you leave the technology to do its own thing, the more stable control you get. And often second guessing the algorithms causes more problems than it solves. And that's just something to bear in mind for anybody that's out there on these sensor augmented closed loop type systems. Now, the reason why I think technology is going to fundamentally change how we deliver type 1 diabetes care is because this is a schematic of how we offer type 1 care in Scotland just now. And I think it's probably representative across the UK. So there has been a bit of work, and Diabetes UK have done this work as well, about trying to prevent DKA at diagnosis. That's something that's going to be very challenging to change unless you introduce screening to detect antibodies. We focus very much at diagnosis about early insulin adjustment, how to teach you how to carb count. And then quite often you would go on through a structured education program. And if you were still having problems or challenges with your diabetes, you then might end up on a pump. And then quite often, if you're having issues such as hypoglycemia or considering pregnancy, then you'd go on a sensor augmented pump. And that's really where our pathway stops just now, unless you were having ongoing issues, in which case we might look at islet cell and things like pancreatic transplantation. If the bionic pancreas fulfills all its promise, then this is what our type 1 pathway might look like. We would still have challenges of preventing DKA at diagnosis, but you could see that as a new type 1, you may actually just get taught how to fill your device with insulin, how to fill it with glucagon, and how to apply a sensor. And you basically let this automated system manage your blood sugars. And the main education you would really need over and above the technical aspect would be how you had some sort of rescue therapy with a pen should your pump fail. And that's a significant sea change to what we do just now around carb count and insulin dose adjustment, structured education. And personally, I think these technologies have the ability to be transformative because they'll cut through a lot of health inequalities. We know from evidence in Scotland and the UK that if you are from areas of deprivation, your chances of getting access to technologies is less than if you're from affluent areas. And that's due to lots of different reasons, but not least because there's an expectation that you need to be able to carb count and dose adjust before you would even get put forward for a pump. And of course, for many people, those numeracy skills and literacy skills that you would need to complete that education isn't something that might be readily available. And therefore, we have got a real concern just now that the existing technologies might actually make health inequalities worse rather than address them. But if these new devices are going to be genuinely plug and play, we might have a chance to redress that imbalance. And I haven't touched on stem cell therapy today, but that might be things that we're looking at as well in terms of biological cure, whether it be stem cells replacement or things like immunotherapy, as I've already discussed. Just a couple other sort of innovation updates then. There are people working on nasal insulins and buccal insulin. I wonder if anybody on the call ever tried the inhaled insulin that was available a few years ago. I think, in all honesty, if we get the technology aspect right, then you would increasingly see less of a role for these, but nonetheless, there is work in this area. A few other future initiatives that are being worked on as well. I don't know how many of you remember the film Minority Report with Tom Cruise. I can't see any of the chat function, so I don't know if anybody's humouring me and responding to that. But this was effectively when they used artificial intelligence to predict who would commit a crime. So this was very much saying that we could arrest somebody before they even committed the crime because artificial intelligence would allow them to have such good predictive modelling. It didn't end well for Tom Cruise. That's a bit of a spoiler alert there. So I'm not saying AI is everything, but AI is fundamental now in our diabetes care models. So we've already had our first FDA-approved AI device to detect retinopathy. So not only would you get your eyes photographed, but the artificial intelligence and machine learning would work out the extent of your retinopathy and automated referral pathways. And there's a lot of work that we're looking at just now, some projects in Scotland looking at modelling for predicting complications. So almost trying to identify what the markers are in advance to identify risk upon risk upon risk so that you can try and intervene as early in the process as possible. And the advantage there is you can drive precision medicine. So instead of a one size fits all, you could start to target interventions. So somebody might actually get an ACE inhibitor, so a drug that can improve your kidney outcomes even before they were to develop evidence of kidney damage, because you can use that predictive modelling. Some of the other areas around innovation are looking at home retinal screening. You can take a photograph with your own device at your home. There's already available some home urine testing for albumin, and we're trying to develop things like foot automated risk tools. So these are all developments that might influence how we manage type 1 diabetes, but also screen for it in the future. I'm just going to finish off talking relatively briefly about what virtual care models look like. And I think it's fair to say that the last 18 months has been a challenge for everybody. But being an optimist, I think from adversity always comes opportunity to think about whether the models of care we had worked well, and if they didn't work well, what we could change. And of course, I think for type 1 diabetes care, we're really talking about virtual care. So I think the new norm, as per this meeting shows, although hopefully next year will be face-to-face, is that lots of things are done virtually. So whether it be meetings like this on Teams or Zoom, whether it be using your glucose data via LibreView or Dexcom Clarity or CareLink, whether it be your actual clinics being performed virtually, this has overnight become the new norm. And, these were slides that I used 4 years ago before we'd even heard of COVID. And I was saying, I'm not sure why we couldn't have a vision for diabetes care whereby you get a text on your phone saying you have an appointment coming up. Why don't you book online and you can make an appointment at something I've termed a health and well-being hub. And my personal view is I see no reason why this couldn't be in shopping centres, why it couldn't be in community-based assets, why we couldn't remove a lot of the health stigma that's associated with surveillance of long-term conditions such as type 1 diabetes. Particularly now, look at the amount of retail space that's available. Why don't we set up some sort of health and well-being hub in a retail space? And there we could do all the processes of care to stop people going to lots of different appointments for this. But actually, let's be a bit more aspirational. And if you've got other long-term conditions, and I appreciate this is particularly relevant maybe for type 2 rather than type 1, but if you had things like COPD or asthma or cardiac problems, then why don't we do all the screening at the same time rather than 4, 5, 6 appointments? Because as an individual, you don't look at your diseases in silos, so why should the healthcare system? And again, I think if we got this set up right, then surely our health and well-being hubs shouldn't just focus on medicalising things, but offering support, whether it be smoking cessation, pharmacy advice. I actually think involving third sector. So this is a brilliant example of a charity organisation running an event that offers much more support than we could ever manage in the NHS and make that a key component of our healthcare models. I think we should focus much more on mindfulness and mental well-being as well as physical well-being, because in diabetes clinics, we focus so much on HbA1c and time in range, but actually it's the person behind the diabetes that's more important than the diabetes itself. And one of the things that I think, having worked, Jude and I have worked in sort of homeless environments and things, then financial inclusion. So many people are struggling just now, not because of their medical issues, but because of their social determinants of health, like financial challenges. And why not include financial inclusion within our totality of a sort of a holistic care model? And in Scotland, we're lucky because all of the results that we could take in the Health and Wellbeing Hub, you can access via My Diabetes My Way in advance of your appointment. And that means when you go to your appointment, whether it be with the DSN, the dietitian or the consultant, then it's not that global judgment. You're not waiting to find out what your HbA1c is. You would know it in advance. And you could actually go to that meeting as a meeting of equals where you say, I see my HbA1c is at 72. I'm not happy where it is just now. What could you help me with to try and improve the situation? Or indeed not talk about HbA1c at all. Focus on something that's much more relevant to you, but make it a genuine joint sort of goal setting encounter. And from the first session this morning, when we did a bit of a Q&A of things you'd like to ask at clinic, it's quite clear that the consultant appointment's often viewed as this global judgment rather than as a sort of supportive mechanism for a lot of people. And you know, it's always sad as a diabetes consultant to hear that. Couple of things that might come. You're already aware that we use more and more time in range. So the more people on Libre and CGM devices, the more we talk about time in range. And SIGN did a rapid evidence review for us that shows that it's comparable to HbA1c for predicting risk. Another thing that we're looking to develop is to actually develop home HbA1c testing. So I think we do want to still be monitoring HbA1c, even if we're getting lots of data from devices. So we're looking at this sort of scenario whereby once a year, you might have your face-to-face appointment where you can get all your screening done, but we could potentially give you away a couple of home HbA1c tests, and you could test it 4 months and 8 months, and you basically just test at home, send it into the laboratory, it would get analysed, and you can review the results on, you know, citizen portals like My Diabetes My Way, as I say. So to finish off, I've covered quite a lot of different things there, and hopefully it's not been too much of a smorgasbord, but I think ultimately preventing type 1 will always be challenging for the reasons I've said, but maybe that targeted intervention and early in the process, as we've seen with some of the immunotherapies, will be feasible. We do know that technologies are advancing very rapidly, and as per the keynote at the opening, it might be that technological cure is not that far away. And increasingly we get asked, are these virtual care models here to stay? Well, I think they are, but it might be that that blended face-to-face virtual is important. And one of the areas that I feel really passionate about, though, is that we don't leave people behind. And we have to be mindful of digital exclusion. We have to be mindful that these types of models don't suit everybody. And we need to ensure that we offer services and care models that support everyone, not just the people who are able to navigate the NHS. And that is a challenge, because the reasons why people struggle are different for different people. And I'll finish there, but happy to open it up to Q&A. And apologies if that was a bit of a rattle through lots of different areas. Oh, this is a final plea. Anybody in Scotland, we're running a big national study just now looking at the impact of COVID. So if you, it's not just have you had COVID, but it's more, has COVID impacted on you? It might be just your life. And so there's a questionnaire there. And then there's also one for people who've been diabetes and COVID. But if you're interested, you could just Google that and feel free to take part in that survey. So that was a shameless plug there, Emma, I'm sorry.
No apology necessary. I'm sure we all agree that was an incredibly helpful and informative talk, Brian. I really like your idea of this. It's very sort of futuristic. Imagine us all in shopping centre, but having a one-stop shop for feet, eyes, and everything else that goes with diabetes. I mean, personally, that would be amazing. And that really is sort of putting the patient or the person first, isn't it? And thinking about it from the other way instead of from the hospital in. So, I mean, I can see by the chat and the questions that clearly people enjoyed it, and you've got people's thinking about it. So I have some questions for you.
Okay.
Good one from Laura. How fast do you think the NHS guidance on getting the new technologies will move? And will people get funding from these types of devices?
Yeah, so that's a great question. And I would love to be able to sit here and say, if you get, if you fit the clinical criteria, you'll definitely get access. We've recently refreshed the Diabetes Improvement Plan for the Scottish Government, and one of the commitments is about timely access to technologies. But I know that that doesn't always translate into health boards funding these technologies. We have got the Scottish Health Technology Group doing a health technology assessment just now, because I think pound, shilling and pence is important. It's, is this an economic argument that we should be making? I think the most important thing is that we as a diabetes community continue to speak as one voice. We've tried to change the narrative in Scotland that CGM isn't just about recurrent severe hypos or pregnancy, that there are wider clinical criteria for CGM. And I think quite often people go to their clinics and they're told by their consultant or their DSN, oh, you don't fulfill the criteria for CGM, so that won't be funded. I would just say, review the guidance, see the nice criteria, think about if you would fulfill that criteria, and then make the case based on that. And we're trying to increasingly encourage healthcare professionals not to be the barrier. Ask the board the question. We've made no apology in Scotland for saying I think that more than 70% of type 1s will need artificial pancreas systems. There will always be a group who don't want technology, and that's fine. But 70%, that comes with it a massive price tag. And we've tried to land it on the National Planning Board's agenda for the whole health economy of Scotland. They're cited on it, so they know it's coming. But I think we just have to keep chipping away, and the more different groups that can apply pressure, and never underestimate, I hate to use the term patient because I don't mean patient, but person power. Individuals living with type 1, their families. You guys' stories are heartbreaking and amazing all at once. And they're very important narratives that we need to build on. And that's what I mean by third sector working together with clinicians, working together to drive this agenda. So that was a very long-winded political answer to say, I don't think it's going to happen as quickly as any of us would want, but we need to keep chipping away at it.
And I think personally, I think that this is where this conference is amazing. So I mentioned to Brian before that I have some friends whose children were diagnosed before my son Hugo, and I keep them appraised of the latest information. They haven't been able to come to the conferences because of all the important information that we hear at the conferences. So I've been every year for the last 5-6 years, and being on the receiving end of knowing what is available, it enables you to go into your clinic, doesn't it, and ask, and can I get this? I really think that this will be a better for my child. And so that has been really helpful for us. And certainly after each conference, we always change something, and we've changed tech after a lot. I think we're on the tech that we like now.
Yeah.
Yeah.
Yeah, there's no doubt there's a strategy to be played here. And that does concern me, because clearly we know that well-educated middle classes are able to navigate the sort of game, if you like, the strategy of looking up the guidance and articulating the ask, which is why I think some of the newer technologies that cut away through all of that will open this up for a lot more people. But yeah, knowing why, my problem just now is healthcare professionals often don't ask the question of their board. So we don't get the board to be responsible. I mean, you know, I'm sick of this, oh, we've got 50 pumps this year and 20 CGM. Oncologists don't have that conversation. Oh, we've got chemotherapy for 50 lung cancers this year. And that's a narrative that I think we need to challenge. I think we should be challenging this set number of devices. I think you should get access to technology based on clinical need. So I don't think everybody should get it, because pumps, and if somebody's, you know, not necessarily as engaged with their diabetes as they would need to be to manage a pump, it becomes unsafe. So I'm not saying everybody and anybody should just get these technologies, but we should be driving timely access to the people who merit on clinical grounds. And the same way oncologists would make that case for chemotherapy. So that's why we have to be mindful of saying, oh, everybody should get it. Well, no, they shouldn't, because it's not for everybody. But if you fulfill the criteria, you should.
Hopefully, Esther, that answers your question. Esther's mentioned the iLet does look amazing. That's not available to anyone at the moment, but some of the other closed loop systems are available, but are not necessarily being given out in all of the clinics. I know that there are some hospitals, some clinics that have better access to it. I know that we struggled to get a pump in the first clinic we were at, and we moved and got a pump straight away.
Yeah.
And we were actually given the heads up by the nurses in the first hospital, you might want to move hospital, which was interesting.
So it all comes down to funding. And, you know, Scotland, we've got 14 health boards who potentially take different approaches to how much they're funding these technologies, despite us nationally trying to challenge that and drive that. In England, I think there's something like 250 odd CCGs, all of whom take quite individual approaches to whether they'll support it. So in England, actually, if a CCG supports this technology, you actually do really well. But if they don't, you really struggle. So I think that's wrong. And I think it's something we should challenge. And I think we just have to keep pushing the clinical case. And with the clinical case, I mean the whole quality of life, person-related stories, because I think they're really important. MPs, politicians don't want to be unpopular. So I think in Scotland, we've got political support. That's why we've got it in our national policy. And I know that's true across NHS England, Wales and Northern Ireland as well. It's the payers that can often be the barrier. And if anyone's got any bright ideas as to how we navigate the process, then please let me know.
But I think this is a great step. We're learning about what is available at this conference. And so it's something we can then discuss in the clinic and ask for it, and hopefully more and more people asking, there's going to be more demand, more, hopefully something that can be done. Another interesting question, are you seeing new diagnoses in type 1 in people who've had COVID?
Yeah, so the COVID question is a great question, because we've seen a lot of people present with new onset diabetes with COVID who are very, very insulin resistant, very unwell in DKA. Now, whether that's an actual insult to your pancreas from the COVID itself, or whether it's an unmasking of type 1 and type 2 diabetes, only time will tell. And I don't mean for the individual, I mean for the sort of narrative of this disease process in its totality. We do know that COVID's got a predilection to the pancreas, potentially. I think paediatric centres are beginning to, there was a real drop in the number of new cases being diagnosed because people were presenting later. But whether that will increase, we'll tell in the next 6 to 12 months, because there's so much variation in type 1 diabetes anyway, you need a bit of longitudinal data to tell whether there's an actual direct effect of COVID or whether it's just moved the diagnosis further down the line, if that makes sense. So I think it's a watch this space, but it will probably have some form of signal.
Has there been an increase in the number of type 1 diagnoses since COVID broke?
So it's too early to tell because there's so much variation. There's monthly variation in type 1 cases. As I said right at the beginning, we were like, we're hardly seeing any new type 1s. But I think it was just because people were presenting later. And then, of course, you then see a massive spike when things opened up again. You don't know if that's just a catch-up spike or a genuine spike. So I think it's a watch this space, as I say.
Okay, what kind of technologies are coming in insulin, making insulin work faster, and also in non-invasive sensors and cannula improvements?
Yeah, so it's funny. So Friends for Life, I met Ed at a couple of meetings before Friends for Life, but having been at the same meeting with Ed, got a chance to speak to him and really try and pitch Scotland as a place to come and try the islet. And they're pretty happy that their algorithms work quite well off of NovaRapid and of Humalog and things. So although you hear about all the ultra-fast analogues that are coming, it would simply be a matter for these bionic pancreases of then factoring that into the algorithm. They should, in theory, handle the postprandial hyperglycemias better. But I think for any of you who've tried Fiasp, it probably didn't deliver quite as much as I think Novo Nordisk suggested in terms of rapidity of onset. Maybe that's unfair. Maybe some people benefited, but not everybody. So I think the important thing will not necessarily be about how rapid analogues work in these technologies, but how the algorithms within the technologies factor in the duration of insulin. And it might be that ultimately we end up with rapid acting analogues within these devices, and it much more mimics what your pancreas would do. In terms of sensors, I've heard about contact lens sensors that might be becoming available. I think the big challenge is trying to get what's called the DMARD down, which is the variability and the accuracy of these devices. And that becomes even higher when you start to link it to a pump. So it's one thing having an inaccurate contact lens reading, but if it's driving your insulin delivery, you need to make sure the accuracy is way up there, which is why probably CGM is likely to remain the gold standard for some time.
Yeah, okay, that's great. Another question from Alexandra, just up the road from me, Alexandra, in Milton Keynes. Do you have any inside knowledge on when Omnipod 5 will be available in the UK?
No, so this came up during the sponsor sessions, and Advanced Therapeutics, Insulet were very much a watch this space. So no, I've heard mutterings, but nothing definitive.
Okay, perfect. The My Diabetes My Way, can you just speak a little bit about that? Because just in case people haven't heard, I remember hearing about it and I haven't done anything about it.
Yeah, so in Scotland, we're very fortunate. So this was started off as a spin-off from Dundee University, and effectively it's a citizen portal. So effectively, individuals with diabetes can access all their own results, their retinal imaging, their foot risk stratification, their blood pressure, but it's also got quite a lot of educational material on it. So the ideal scenario is that you get registered, and that's in Scotland, although I think some areas of England now have My Diabetes My Way available as well, so it would be worthwhile checking. And then basically for security reasons, your healthcare team need to validate that you are who you are. You then get set up with an individual account that takes you into your very specific portal. However, for people who are on the call not in Scotland, if you Google My Diabetes My Way, although you might not be able to set up a personal account, they've got loads of resources there, whether it be carb counting, type 1 educational resources, information about pumps and stuff. So it actually is just a really good diabetes resource, albeit the cherry on top is when you can access your own data.
Which is fantastic. So I guess the answer to that, we should just Google it, see if we have access to it.
Yeah.
And okay. Now we've got some other comments. I know it was Alexandra, I'm just trying to find it. Alexandra mentioned that she put added names to the Address 2 trial when her daughter Maya was diagnosed, but she hasn't heard anything since. Is that something that, are you aware about the trial?
Yeah, so to be honest, I'm not a trialist in the Type 1 network. A lot of it's addressed at the paediatric community. I think there's probably nothing wrong with sending up a follow-up email, just saying, you know, it might be that the studies that they've got just now have already recruited. And that's why you almost, you need it within the first 100 days for quite a lot of the immediate therapies. But if you've got, you know, if it's your children, for example, if they've got siblings, then they might look to recruit sibling studies. And that was the trial I mentioned about delaying the onset of type 1. That was pretty much a sibling or relative study. But we do no harm in chasing that up with them if that's an area you want to get involved in. It's a really difficult area because the first 100 days, your head's already all over the place without worrying about getting involved in a trial. And particularly, well, I can't even begin to imagine if it's your young kid as well that you might be putting through research visits, additional bloods and stuff. You have to weigh that up pretty carefully.
And see how much headspace you have. I
mean, yeah, exactly. But ultimately, a lot of these advances have been made because of, you know, that trying to do that tertiary prevention work type thing.
Yeah. Now, unfortunately, I think this is something we could keep talking about for hours, but we have come to the end of the session now. So thank you ever so much. As I say, I think this is one of the things that I love about this conference. One is just meeting so many like-minded people, and for it to be so positive. Everyone is just looking forward, you know, we've got this, and it's a real lovely community feel. But also hearing about the latest research and developments and the cutting edge technology. This is what I think keeps us all going with this conference. So thank you ever so much, Brian. That's been really...
not at all. Thanks very much, folks. Enjoy the rest of the conference.
Enjoy the rest of your day, guys, and do check out the sponsors. Bye.